Hey, everybody out there in video land, or maybe you're in podcast land walking around the neighborhood. Maybe you have a pit mixed dog that you're walking because she hasn't been out in a while. But wherever you are, this is John Marshall for Oncology Unscripted. And I am a lucky guy because I am joined today by not only a great friend, but also someone who is really setting the standard of care for us in so many ways in GI cancers. And that's Dr. Yelena Janjigian. Yelena, how is New York City today? How is it up there?
Thanks for having me, John. It's great. New York is the best place to be. It's beautiful and sunny. Getting ready for holiday season. It's always good to catch up with you and talk research and talk gastric cancer and esophagus cancer outcomes.
Do the stores already have like decorations and ready to go up there as we
I have
start?
not been out, but I've noticed some things here and there in offices.
What do you mean you haven't been out? You live in the hospital, in the clinic? Don't you
Not
go out?
out in shops. Yeah, but I'd noticed a few holidays actually. Some of the actually skipping Thanksgiving, going into holiday season decorations and random offices. So, but yeah, the spirit is cheerful in New York as
Good
always.
time of year. It is a good time of year. I know you very well, and I know lots of our listeners know you very well. Give us a quick little bio on what you're doing right now.
I'm a physician scientist working at Memorial Sloan Kettering, focused in advancing care and helping patients with esophagus and stomach cancer live longer using both targeted and immunotherapies. Our lab is focused on trying to understand how we can overcome resistance to some of these medications using both tissue culture and also models. And of course, I also lead a big group at Memorial Sloan Kettering. We have 45 oncologists all focused with one mission to improve cancer care for and worldwide options for gastric, but also anywhere covering from esophagus down to the anal canal. So it's a big group of very dedicated individuals.
So now I know why you haven't been outside because you haven't slept, you haven't left. I'm hoping there's
Annual
going to be
review time. A lot of paperwork.
But let's get into the weeds a little bit on how you are, in fact, helping to lead the improvement in outcomes for patients. But before we jump in, as an old guy in this space, I do have frustration that we in the GI cancer world haven't made more progress compared to our friends in some other cancers. And I know in upper GI and stomach and adenos, et cetera, precision medicine hasn't been consistent. Things that work in the metastatic setting haven't necessarily worked in the adjuvant setting. It's taken us a long time to get precision medicine targets that are viable for our therapies, et cetera. What are your thoughts about that and why that might be so?
Yeah, I think important to start from basic knowledge that this disease can be quite heterogeneous, even in biomarkers such as HER2, cut and paste approaches from, for example, breast cancer into gastroesophageal cancer have not been the best way to do it. In fact, understanding the co-occurring alterations in our disease, the RAS pathway activation, the PD-L1 co-occurring with HER2, and is what made the major milestone in the breakthrough in first-line setting beyond trastuzumab. So I think understanding that this disease in its nature, because of the nature of the GI epithelium, is more complex but also heterogeneous than some of our other solid tumors is really critical. And also, because it's a rare disease in some countries, uniform and reflexive testing of biomarkers, where you get enough of a critical mass of data into the clinic so that you understand how each individual subset of a subset, for example, within HER2 tumors, p53 mutant tumors may do differently than p53 wild type, RAS amplified versus RAS, neutral, things like that. Until we do things in larger scale, really going forward for all patients, we won't understand this nuance. Because in colon, breast, lung, the big three, there's more of a data breadth and depth that these discoveries can be made.
Yeah, I was thinking about, I do mostly colon cancer, and we've been seeing with IO therapy, where we're going to go in a minute, that even in MSS colon cancers, if it's primary disease, we are seeing responses when we would never see them in metastatic disease. So we're looking at microbiome interface or different biology of primaries versus mets. That's sort of what you're doing here with the Matterhorn study, is you're taking some leads from metastatic and applying them into the neoadjuvant adjuvant setting. Does that feel right to you?
Yeah, that's right. I think that whole paradigm of go to the late stage setting, demonstrate benefit in heavily pretreated population, and only then move it to metastatic early line, and then only then move it to adjuvant or neoadjuvant space. That's where the oncology field, I think, lagged in understanding of bigger leaps, move to perioperative setting or a minimal residual disease setting, because you may not demonstrate a signal that you want in a fourth line ECOG 2 patient with peritoneal carcinomatosis and ascites. By then, it may be too late. And even that's what I think helped me bring, for example, agents like pembro-tras combination KEYNOTE-11, because doing studies in later line, you understand that HER2 target becomes even more complicated. And again, targeting HER2 with just better HER2 inhibitors together, as was working in breast, was not working in gastric. And so moving it to first line with dual immune checkpoint and anti-HER2 combination was the paradigm shift. And I think that's we're trying to replicate in some other biologically important subsets of cancers.
I'll spare you having to do the weeds of the study. So the Matterhorn study, neoadjuvant FLOT plus minus durvalumab, regardless of PD-1 status, or as you measured tumor area positivity, or both really, with pre-op, post-op kind of approach, placebo-controlled, maintenance afterwards, big study, global. Josep Tabernero is always good to have as a first author. You're the senior author. How much of a pain in the neck is it to run a big clinical trial like that?
It was fun to do because we had to convince industry partners to do the study, because Merck has already had a phase 3 registration perioperative pembrolizumab study going. So to convince AstraZeneca leadership that their design was not as optimal as the modern FLOT approach.
So high risk, high reward in some theory, right? But you're
That's
asking
right.
them to roll a bunch of dice, aren't you?
948 patients. And to be able to present that data, so it was presented at ASCO in the plenary and then published in New England Journal of Medicine, was definitely a high reward. And for the patient, and for the community to be able to unify East versus West, put it all in the same trial. The trial actually accrued ahead of schedule in the time of global pandemic. And it was always really rewarding to be able to tell patients that you had a great response, complete response, and to see the R0 resections, because the dogma was that you need radiation, for these patients. And we've moved away, even, now increasingly in the community setting. I hear, we just did a large CME conference, and clinicians came to me and were saying, this is perfect time for you to update us about this. I'm taking this to the clinic. And it's part of NCCN guidelines now.
And so give us the high level. I mean, you got survival benefit, you got PFS, you got response rate delta, toxicity as expected, not zero, but as expected. Just high level for our clinicians out there. What are the numbers they walk into a room?
The timeline of this was at ASCO, we presented the PathCR and EFS data, which was also published in New England Journal of Medicine. And in Berlin, this just past ESMO, we also presented, and this was a big splash because it's been shown with immunotherapy before that PathCR may be improved, but will it translate to event-free survival? Check. And then for the first time ever, we were able to demonstrate that you will also see an OS benefit. And that was the splash at ESMO. We will be publishing that data in a manuscript format. So to show that a PathCR can be an early surrogate of survival, I think it's all important for us as researchers, because in my program have 3 separate first in sort of ISTs in perioperative setting, building on Matterhorn. So to know early which of the strategies will be successful to take forward in phase 3, waiting for PathCR would be much more practical. And so that is important. I think one common sort of public service announcement I wanted to make: people are still a little confused about the nomenclature of the cycles in the Matterhorn. And in fact, that's probably one of the most common email or direct message I get on public media is, why did you only give 2 cycles of FLOT? We did not. A cycle was defined as 2 doses of FLOT. So it's 2 cycles, but it's 4 doses of FLOT and 2 cycles of durva. So durva is given once a month, FLOT is given every 2 weeks. So this was, as you said, standard approach. And we did see improvement in event-free survival. And what's important to look at, not only the hazard ratio, but the 2-year survival benefit, which was meaningfully improved. And the grade 3-4 toxicities we need to be careful about. Most of the side effects are related to chemotherapy. So as the clinicians are getting more and more comfortable using FLOT in the clinic, the dose reductions, the hydration, the prophylaxis, potentially with neoadjuvant if needed, all of those will be implemented and will be used. So NCCN already adopted this regimen, and we're planning hopefully for the FDA approval in the near future.
Yeah. I think about the number I go in with oxaliplatin in the adjuvant setting in colon, which is, overall maybe 3-5%, depending on how optimistic I am on that day. Here, what's the number I walk into the room with a patient? Is it another 5% or so are cured by the addition of the IO therapy to FLOT? Is that a fair number to walk in the room with?
I would say, well, it depends on so for looking at a final OS, so the difference was closer to 7%.
Take it. So a little higher, more than
Yeah.
5%, I can say. All right. And that tail does exist, and you've got enough follow-up for
Right, and
the
that's at
patient.
3 years, yeah. And
Yeah.
then I think that if you think about it, this is looking at a large phase 3 study. And these are all patients who did not have all laparoscopies. They didn't necessarily have the staging that you and I could do in our practice with subspecialty care. So I suspect that number is, or at least in our hands of tertiary cancer center, is better.
Going to hold up okay. Tell me about PD-1 testing. I realize everybody could be in on this study.
So it was an all-comer accrual. We used we used tumor area positivity as opposed to combined positivity score. It's reproducible, and there's data to show that TAP and CPS are equivalent. And the benefit appeared to be irrespective of PD-L1.
So they could come in cold for PD-L1 and they're still eligible for this therapy based on the study.
NCCN restricted it by TAP1.
Okay.
It's unclear for inquiry reasons. It may be amended because this was a restriction before the OS data came in. So we'll have to see. The EMA appears to be interested in approving it, again, just from a discussion with colleagues in Europe, irrespective of PD-L1, because that's the huge patient population. Irrespective of that, most tumors are PD-L1 positive. So if you're seeing a negative case, I would call your pathologist to make sure the cellularity of the case is sufficient.
Take a look again. I think immunotherapy is certainly one of those classes of drugs that we have the highest patient awareness. They're always coming in and saying, shouldn't I have some of that immunotherapy stuff? And in some cancers, it can be quite dramatic, the impact. What's your thought, and what are we doing about trying to further optimize the impact of the immune system on treating our cancers? Where are we with that?
Yeah, so our large biomarker analysis of CheckMate 649, which was the FOLFOX-NIVO versus FOLFOX stage 4 patients, showed that chromosomally unstable tumors, so CIN tumors, the hazard ratio in metastatic setting for addition of immunotherapy is not as good. It's 0.9 for survival. So we know those tumors don't do as well. How do we improve on, because they're relatively cold or immune excluded tumors, so we're trying to boost that. We know that combined immune checkpoint blockade with CTLA-4 inhibitors may offer some benefit, especially from the data we see, as you said, in early stage colon cancer, but it's very tricky to combine it with FLOT chemotherapy, the historic CTLA-4. So combination with TIGIT may be helpful because, again, it's an immune boosting dual immune checkpoint blockade. That's to be determined. There's also now FC silent bispecifics with PD-L1, CTLA-4, drugs like cadonilimab, which are approved in China and actually are coming to United States as well in metastatic setting. So that's what I'm interested in. I think subset of patients, it'll be a combination of PD-1 plus tumor targeting for example, HER2 positive tumors. Subset of patients, it'll be dual immune checkpoint blockade, either PD-1 TIGIT, if that data pans out, or PD-1 CTLA-4, with the backbone of chemotherapy, first of all, because it's been difficult to move away from chemotherapy unless it's MSI tumor.
Tell us how we move forward. What's next out there for the treatment of upper GI cancers?
Well, today we had a press release that zanidatamab data appears to be positive, Horizon study, whatever that will be. So for HER2 positive space, it'll be interesting to see at ASCO GI. And then, of course, the biggest disappointment of the year is the FGFR2b data with bemarituzumab, with Fortitude 101 having a huge splash with a large positive interim analysis that subsequently dissipated and the curves came together, as you probably saw at ESMO. I think it shows that we're not quite done with biomarker development in gastroesophageal cancer, and the best is yet to come.
Just to let you know, from Washington, D.C., that wasn't the biggest disappointment of the year. There's been other stuff that beat that, but we don't have to go into that today. Dr. Yelena Janjigian, world's expert and really thought leader in the space of upper GI cancers, moving the bar, curing patients right and left, not just in New York City. Go shopping, get out of there and enjoy a little time. You've deserved it. But John Marshall, on behalf of Oncology Unscripted, thank you, Yelena, very much.
Thank you so much, John. Be well. Take care.
Bye-bye.